Hello, everyone, and welcome to today's webinar. My name is Derek Noland, and I am a community liaison here at the Behavioral Health and Wellness Program at the University of Colorado School of Medicine. This webinar is the second in the spring webinar series for the Tobacco Innovative Grant Project, which is designed as an innovative project focused on reinvigorating whole health programming, specifically by including and/or expanding tobacco-free services, procedures, and environments. As part of my role at BHWP, I manage this project and offer technical assistance to organizations in Colorado that pledge to make changes related to their tobacco treatment services and policies. We will have some time for questions at the end of today's session, so I ask that you please hold them until that time. After completing today's webinar, my hope is that all attendees will be able to define and describe low-burden strategies for tobacco cessation interventions, also to examine several concrete actions that can be taken to provide effective and efficient tobacco cessation services, and provider resources to support rapid improvement planning and the implementation of tobacco use disorder services. So to reiterate, again, this is the second webinar of the spring series for the Tobacco Innovative Grant Project, or the TIG project. The TIG project is funded by the State Tobacco Education and Prevention Partnership, or the STEP program at the Colorado Department of Health and Environment, or CDPHE, in order to provide training and technical assistance to organizations across Colorado that are interested in implementing and/or expanding their nicotine policies and tobacco treatment services. Later this year, during the summer, BHWP will be releasing the Behavioral Health Cessation Coordination Model Toolkit. We released the BHCCM model itself last year, but the toolkit will provide organizations with a blueprint for how to utilize the model and how to evaluate the tobacco treatment services that they offer. Looking forward, BHWP will be continuing to create new toolkits in the years to come via this project, with a tobacco-free toolkit for healthcare providers on the docket for next year, which will include an addendum focused on behavioral health populations. All these materials will be uploaded to the BHWP website, www.bhwellness.org. You'll see that link again at the end of the presentation, and they will be available for free public download. Finally, note that there are currently openings in the cohort for next year's TIG project. So if your organization or one you're aware of might be interested in participating and again, implementing and/or expanding their tobacco policies, please contact myself, Derek Nolan, for more information. So in the last webinar in the spring series, which was titled An Overview of the Opt-out Model for Tobacco Cessation, this webinar is currently available to view on our YouTube channel. You can type in the Behavioral Health and Wellness Program in YouTube to find that. This webinar and the other two from the spring series, including this one, will also ultimately be uploaded to our website as well over the summer when that page is revamped. In regards to the opt-out model premise, which presumes that all people who report tobacco use will automatically be referred to treatment, I should point out that this webinar today is not necessarily operating from that standpoint. Generally speaking, the more common opt-in approach is in focus here. Still, that said, this webinar fully applies within opt-out settings as well. And more to the point, the opt-out model remains a superior approach for routing claimants to treatment services. If you're interested in learning more about that model, I encourage you to view that webinar. Okay, moving into today's topic. This webinar's overarching learning objective is simple. I want to highlight several actions that organizations can take to move in the direction of providing a comprehensive suite of effective, efficient tobacco cessation interventions, ideally with the resources they currently have, which is to say that they must be low burden in either their time requirements, their financial costs, or both. To do that, I intend to not only define what we mean by low burden, but I will also list and describe some of those actions. So before getting too far along, I want to address the term sustainable. Typically in these types of presentations, we would talk about scalability and sustainability. Well, one point I like to make is that as a general rule, all scalable initiatives are also sustainable, but not necessarily the other way around. So of the two, being sustainable is in fact more important. And I am essentially using the terms low burden and sustainable as synonyms, not precisely synonyms, but similar. Low burden emphasizes the impact on staff today, and sustainable emphasizes the feasibility of maintaining these improvements over long periods of time. In BHWP's experience in this field of work, changes perceived as low burden today are much more likely to become sustainable over the long haul. So by low burden, we mean primarily two things. One financial and one psychological. Firstly, the benefits delivered are worth the costs incurred to deliver them. And secondly, those benefits are understood and appreciated by those who perform the services. Regarding number one, in a narrow sense, we could be talking about ROI, or return on investment. If we determine that the project costs an additional $100 per consumer, for example, but saves the organization $200 per consumer, we'd say that the project is worth doing. But we may consider it worth doing even if the ROI were narrower, or even if the project incurred some cost, provided that the project serves some other purpose important to the organization, such as fulfilling its mission to care for the community, for example. On point number two, we're primarily talking about the culture of the organization itself. Many tasks have been forced upon employees over the last 20 years or so. Caregivers spend anywhere between 40 and 70% of their day doing administrative work instead of providing actual care. No action, program, or suite of services can be considered sustainable if the staff are actively pushing back against the execution of that program, which is all to say that we define low burden initiatives as those that satisfy at least the first criteria and which are housed within a robust policy regime that aids in the satisfaction of the second. So to satisfy criteria one of sustainability, an intervention must work. It must convey some benefits to the staff directly, but more importantly in this realm, there must also be benefits to the consumer. Case in point, a tobacco cessation intervention should successfully get people to quit tobacco. So which interventions work? To know that, we have to understand some things about quit attempts in general and where we can impact them. Here I want to share some back-of-the-envelope calculations. So let me first clarify what I mean by that term. The numbers that will appear on this slide are simply approximations. They take a lot of things for granted, and they haven't been vetted by an epidemiologist or anything like that. To emphasize the lack of precision here, I've done a lot of rounding down to show more conservative figures. I also chose the lower end and upper ends of certain estimate ranges selectively to favor conservatism. This is my goal here because the point is not to exaggerate what is possible, but I'm also not doing this to offer actual projections that might be truly achievable. I'm doing this merely as an exercise to build intuition around the scale of our potential impact and for whom our efforts will be most impactful. We begin with about 38 million adult tobacco users in the US. This number is fairly recent. It likely has decreased in recent time based on some of the newest data that's come out recently, but we'll use this as a good rule of thumb. About 75% of tobacco users report they want to quit within the next year. That's a consistent figure that we've, it's remained steady over the years. Now, these figures are for adults only, but it's worth a brief aside to mention that when most individuals younger than 18 are asked if they imagine themselves as a smoker at 30, they say no, they do not. In fact, by the time tobacco-using teenagers reach the age of 18, 50% of them report having tried to quit already and failed. So now going back to our adults, when we ask them if they went one day in the past 12 months without smoking with the intention of being absent, only about 65% report they did. The group represented by that gap between those two figures, who we want to quit and those who actually try each year, I will refer to this group as Group A, a group of about 4.1 million folks with a 0% abstinence rate at the end of 1 year because they didn't try to quit. A group that, if we could reach them all and persuade them all to use counseling and medication, could result in about 1.1 million additional successful quits. I want to take a pause for a moment after these statistics. Many presentations regarding tobacco begin with an argument, an appeal to why are we talking about this? Why does it matter? I didn't begin with that for this webinar, and I didn't spend time on the burden of tobacco. I did spend time on the burden of tobacco in the first webinar in this series as one reason. And because since you all registered for this webinar, I assume you are on board with the general idea that helping people to quit tobacco is a good idea. Nevertheless, there are some common misconceptions that I feel I should address, and this is the moment where they become relevant because I'm tossing around numbers like how many people want to quit and what are their success rates if they try. Therefore, it's worth figuring out if the behavioral health population may be significantly different than the general population reflected in these 3 bullets. We do know that the behavioral health population uses tobacco at rates higher than the general population. And we also know that they suffer more from tobacco-related health disparities above and beyond what their disproportionate use would predict. What we see is that those suffering from a mental health or substance abuse issue are more likely to lack access to therapeutic services and thus rely on smoking as self-medication or a coping strategy, which drives up use. This vulnerability attracts the interest of the tobacco industry, which increases its outreach to this population, which further drives up tobacco use, both in terms of the numbers of people who use tobacco and the amount of tobacco each person uses. This increases the financial and physical toll of tobacco, which increases the desire to quit, but it also increases nicotine dependency, thus making it more difficult to quit without access to resources, which, as I've already pointed out, they likely don't have access to. This is how we get to significantly higher prevalence rates. To make this point clear, there is a misconception that there are peculiarities within the behavioral health population that makes tobacco use intrinsically more desirable for them, and that makes quitting harder. And that belief simply is not true. In large part, the increase used and the decreased success within this population are both manufactured by the tobacco industry itself and the effective targeting that performs, and also perpetuated through misconceptions held by behavioral health care providers, which can undermine some of the work that they're doing and negatively impact this population. Here you can see some of the details of how the tobacco industry has specifically targeted this population, including, as you can see here, exorbitant spending on marketing and promotion, spending that is vastly greater than what tobacco control can muster, and the explicit promotion of smoking in treatment settings, among other nefarious doings, as you can see here, including monitoring and even directly funding research to promote some of these misconceptions, including around people with schizophrenia who we know smoke at really about the highest rates of any population group. One of the myths that the tobacco industry has perpetuated through these types of actions is that smoking is a good stress reliever for psychiatric patients, and that if smoking is removed as a potential coping mechanism, then psychiatric symptoms will increase. In fact, the opposite is true. Tobacco use causes, contributes to, and even aggravates various conditions. It primes the brain for future addictions. It can increase pain sensitivity and increase the power of certain opioid effects. It can dampen the power of various therapeutic drugs, including certain painkillers like acetaminophen. And in addition to the causal and associational links between smoking and behavioral health, co-treatment of nicotine and other substances can positively affect the chances of remaining abstinent from both drugs. When we talk to individuals in this population about their desire to quit and their willingness to try, we see that the higher prevalence isn't about their desire or their willingness. In fact, the expressed desire to quit is actually higher in the behavioral health population. And what we know is that with the right supports, not only is quitting desirable, it's also a perfectly reasonable goal with similar odds of success as with any other population. Simply put, people with behavioral health conditions can quit at rates comparable to the general population. You can see those figures at the bottom right there, and you may notice that they're more or less identical to what we saw earlier for the general population. So the numbers underline this reality that people with behavioral health conditions do want to and can quit at rates essentially comparable to the general population. One final note on this topic. Several years ago, BHWP had the opportunity to collect a convenient sample of a little over 600 individuals in substance abuse treatment facilities across Florida. We asked those individuals whether they were current tobacco users, whether they were ex-users or never tobacco users, so non-users, And if they were current users, if they selected that they were current users in that survey, we asked whether they wanted to quit in the next year or whether they had no intention to quit at any point in the future. So here are the results that we found. Roughly 31% of the people who completed the survey were either ex or non-smokers. And of the smokers, 65% of them said they wanted to quit in the next year, a percentage which is represented here by individuals who were in the contemplative stage or further along in the stages of change model. So not quite as high as the national figure, but all things considered, really close, and definitely much higher than most clinic directors or senior leadership expected. You can see that a large portion of them were beyond the contemplative stage and actually in the preparation or even in the action stage where they were in the midst of a quit attempt, if not having already perhaps stopped smoking in that period of time, but not quite yet reached the maintenance stage. And we'll return to this, this study very briefly later in this webinar. Okay, now to return to our previous point and our calculations. One area where we can make an impact is trying to reach the missing 15%. Again, this is Group A, the group of about 1.1 million potential new quits if we could somehow reach them and engage them in services. But let's put a pin in that group for the moment and look at the 24.7 million people who do make an attempt. What happens to this group? Of those, most of those quit attempts will be made without any help at all. We do know that the cold turkey or unaided approach, if you will, is the most common type of quit attempt that is made. And it is true that more people quit via the cold turkey method than any other method. So it's quite common to hear success stories from people who have done it that way. But the reality is the reason why more people quit that way than any other way is simply because so many more people try to quit that way. So the problem is that, again, most of those quit rates are unsuccessful. Roughly around 5% do succeed. And if we were able to, provide resources to the people who are doing it this way, they'd be much more likely to succeed. So I'm using the figure of about 60% for unaided quit attempts, which comes from a recent CDC report on cessation attempts. And so only 7% of them will be successful. And again, that's a fairly conservative number. We often see a range of 4 to 7%. So it may even be lower. Okay, so all of this leads us to Group B, the remaining people who attempt to quit unaided, representing those who will not successfully quit in their attempts. A group of about, conservatively, 14 million people each year. Of that group, about 1 million will successfully quit on their own. If we could have persuaded all of them to use counseling and pharmacotherapy, there's the possibility of an additional 3.5 million successful quits in this group each year. And so that's what I'm referring to when I say that if we could reach these people and connect them to better services, they would be much more likely to succeed. We could potentially have a vastly larger number of people successfully quitting. These numbers may appear really pie in the sky at this point, so let me try to bring the point of all this home. When I began in tobacco control in 2015, a common saying that you'd hear around the industry was that there is no more low-hanging fruit, meaning that everyone who would have a very easy time quitting had already been reached. This has also been referred to as the hardening hypothesis, a phrase or theory suggesting that those people who continue to smoke are those who find it most challenging to quit. And on the surface, this concept may make sense. I think it is true that as we continue to pass tax increases and flavor bans and to raise the legal age of tobacco use, we have locked in lower prevalence rates and continue to drive them down. However, in turn, this has inspired growing stigmatization and marginalization of those people that continue to smoke. Those who are left, in other words, are less likely to hear public health messaging and less likely to be activated by it if they hear it. Again, we call these groups hard to reach, and who may also be less likely to receive support from healthcare providers. So I think we need to understand that once we have gone and met them where they are at, for example, at points of care within the behavioral health systems, then they really can become, again, low-hanging fruit. Again, most tobacco users within the behavioral health population want to quit, and in fact, they do try to quit on their own. If that's not low-hanging fruit, then I don't know what is. We have two main tasks that can help reach the vast majority of this population. One, lock in the motivation to quit in that 15% or so of folks that lose their nerve during the year and don't actually attempt to quit. And two, get evidence-based resources into the hands of those who might otherwise elect to try and quit without them. And that may involve some work in the trust building domain. So here we can see all of the various quit rate successes by method of quit attempt. You'll see that I used that 7% to illustrate the unaided quit attempt, again, aka the cold turkey method. And I used 25% as the number of choice for medication and counseling. I did this to create, again, the most conservative estimates for our back of envelope best case scenario. So this leads us to a new group, Group C. And Group C is the collection of individuals who will seek out an evidence-based best practice, but who, without the right supports, will demonstrate success at the lower end of the range. That is, someone may seek out NRT and counseling support, but if they also sought our support, adding our guidance to their toolbox, instead of the 25% chance I gave them here, they may have had 30%. Bottom line is that the evidence base suggests that the best thing a tobacco user can do is to get access to tobacco cessation counseling in combination of nicotine replacement therapy, and or specifically varenicline, also known as Chantix. And so all of our concrete actions are designed to impact groups A, B, and C individuals. And to look at a few other figures on this chart here, we can see that the moment we move people forward from simply having an unaided or unplanned sort of cold turkey attempt to a more thoughtful self-help, mindful approach to quitting, we immediately get a significant bump in the abstinence rate. Quit lines remain a very effective tool for reaching people across states, especially those who may live in rural settings or may not have easy access to healthcare services. Quit line success rates vary by state and fluctuate over time based on the services that the quit lines are able to provide. But by and large, they are a very valuable service at no cost to the individual that typically can provide free medication and counseling sessions. And so we do get a significant bump over the cold turkey attempt when people use that service. You can likewise see that when counseling is introduced, whether it be in individual counseling format or a group counseling format, we again see a significant bump in terms of the success rates of quitting. And then, as I've already reviewed, once we get to medication and medication combined with counseling, we reach our gold standard where we can really see significant success rates in terms of quitting tobacco. So in terms of best practice, what are we going to do next? The recommendation here is that we're going to use the 5 A's, so ask, advise, assess, assist, arrange, in order to implement and deliver the tobacco cessation recommendations of the United States Preventive Services Task Force. If that name sounds familiar to you, it may be because anything with a grade of an A or a B from the USPSTF must be a reimbursable service for the insurance policy to be considered compliant under the Affordable Care Act's Essential Health Benefits section. As you may know, when the ACA was implemented a little over 10 years ago now, it did mandate certain insurance coverage for tobacco treatment services, and including things such as counseling and medication. And yes, it is true that there's a variation or flexibility in terms of how insurance providers may offer that type of coverage. But nevertheless, there is by and large coverage for those services. So those services are specifically, again, I'm referring to the recommended tobacco cessation services from the US PSTF. They are telephonic counseling. So this definitely includes the quit line, any state quit line, I should point out, and it can also include telephonic counseling offered by healthcare providers as well. It includes group support, so the group counseling format that we saw on the previous slide. Some of you on the line may have been trained in BHWP's Dimensions Tobacco-Free Program Advanced Techniques training, which is one example of a group curriculum. Individual counseling, perhaps offered by a certified tobacco treatment specialist, tailored to that individual and responsive to their needs and interests. Peer support, so services led by people who share lived experiences with the individuals they're treating, another powerful and recommended approach. And medication-assisted treatment, or MAT, incorporating medication into that treatment. So in this case, nicotine replacement therapy and the 7 FDA-approved medications for treating tobacco dependence. Some of you are probably familiar with the 5 A's already, I imagine. And some of you may have opted for the shorter version, which appears on the slide here in the middle, the ask, advise, and refer, the 2 A's and R method. And while it's important to understand this framework, you don't need to worry about embarking on a full-fledged 5 A's training here. Just in short, the AAR, or 2 A's and R method, the ask, advise, refer, it's the truncated method, the shortened method for people who don't have the experience or the time or the capacity to embark on the full 5 A's method. When someone does do this abbreviated version, it is important that they're still providing that very clear, personalized, non-judgmental, as possible, tailored advice to quit smoking, pointing out that it's the number one thing you can do to improve your health. And then also it's important to note that the referral need be a thoughtful referral, one that's done carefully and with the best interest of that client in mind, and ideally enthusiastically. We don't want to undersell wherever we might be making that referral to. So perhaps many more of you will be even more familiar with SBIRT, or Screening, Brief Intervention, and Referral to Treatment, which you can now see in the middle here. Because SBIRT seems to map most directly onto the 2 A's and R method, I would like to draw out the difference between the two. In short, the brief intervention component of SBIRT is more complex than the advise component of the 2 A's and the R method. We will discuss referrals in a little bit more depth later, but suffice to say that to make a good, effective recommendation that a person will considering following through with is an important piece. And you do have to do a bit of the assess and assist pieces in order to accomplish that. And whenever you make a referral for an individual with whom you will maintain an ongoing relationship, you should be aiming to close the loop a bit to make sure the consumer accesses those referrals and to gauge their progress. For example, if nicotine dependence treatment is added to a treatment plan to enhance recovery from alcohol dependence, then the case manager responsible for checking in on the alcohol-related services should also be following up on the client's engagement with and progress in, say, the psychoeducational or support group that the patient was referred to for nicotine. Okay, now that we're in our second section on planning, you might be wondering if I will ever get to the doing part, and I will, I promise. It's worth pointing out at this time that planning well, while itself not an activity that generates revenue, reduces expenditure, or improves consumer health outcomes per se, it is nevertheless absolutely critical. Remember when I said earlier that in order to satisfy the most fundamental property of sustainability, intervention must work? In study after study, one of the critical factors in determining whether a workflow adjustment or a new organizational policy succeeds or fails is the time spent in planning and the effort given to creating an honest, quality course of action. We simply cannot skip these steps. And crucial to the planning process itself is accountability. And so we do need to consider who is going to be responsible for doing what. And even more to the point, we need to designate and write down or document who will be responsible for which components of a new process. In the realm of tobacco cessation services, supports, and policy measures, a crucial figure that dominates all others and of which the formation predates all others is, in fact, the Wellness Committee. If the Wellness Committee's only function is to analyze and rework your tobacco workflow, then by all means, it can be called a tobacco committee or something along those lines. Generally speaking, we advise against creating a committee with such a narrow portfolio as simply working on tobacco for a variety of reasons. But the two most important are that a committee with a narrow portfolio may quickly run out of steam while your new policy is in the doing or the action phase. So having a broader scope of focus and work is not to say that the tobacco component doesn't deserve a direct focus, just to say that it will provide, having a broader focus will provide more initiative and more opportunities for the Wellness Committee to have a function and to not fizzle out. But more importantly, tobacco use impacts nearly every aspect of its users' lives. It causes and aggravates the mental health conditions that they are seeking care for. It causes and aggravates the development and progress of chronic diseases, which do things like diminish their ability to find work, maintain housing and relationships, etc. And all this in turn can, of course, exacerbate chronic mental health conditions, for example, like a major depression. Furthermore, it can strain people financially, and simply put, this just goes on and on. So a wellness committee serves as a central point of contact for the creation and dissemination of the new policy changes as they are planned and released. It is the wellness committee which will serve as the main point of creativity, taking the best practices mentioned in this session and elsewhere and modifying them to fit the needs of your consumer population and to fit the needs of your staff's willingness and capacity as well. As you can see here, it is best practice and recommended to include a variety of different types of people and professionals and voices in your wellness committee. This will simply assure different perspectives and ultimately lead to more comprehensive and inclusive outcomes. So you can see many different types of people who may be involved in a wellness committee. I'll point out a few. The Human Resources Department is an important one to include. Neighbors, often not considered within this framework, but can be very important. Specifically, the example that often comes up in this type of work is that if you implement a tobacco-free policy, we might want to let our neighbors know ahead of time so that they can, be prepared for the possibility of people leaving our facility and smoking outside their property. And so we'd want to come up with a strategy to address that ahead of time. One last one I'll point out, it's important to include opponents in this type of work, people who might not agree with some of the initiatives, particularly, again, perhaps a tobacco-free policy. It's good to get those voices, to hear their thoughts, to incorporate them as applicable, not to necessarily do what they're saying, but to have that voice can improve policies and help create buy-in and let people feel that they're being heard and considered. So unfortunately, there is a gap between no burden and low burden, and this gap is not unimportant. So one way to get more new things into a workflow is to first analyze your current workflow and get rid of all the stupid stuff. As an example, in an effort to reduce unintended burdens for clinicians, leaders at a health system in Hawaii asked all employees to look at their daily documentation experience and to report anything in their electronic health record that they thought was poorly designed, unnecessary, or again, just plain stupid. Basically, this health system allotted a certain amount of time for anyone to report anything they did that they felt just didn't matter. Now, critically, some of these things were really poorly designed, and they were able to fix them. Some of these things were unnecessary, and they were simply eliminated. Some things only seemed necessary, so the team in charge was able to explain why those steps were necessary to complete, or why that information was necessary to collect. And some things were holdovers from previous eras, previous initiatives, actions that were necessary and smart once, but were no longer at the present. In all, this system estimated that they were able to eradicate thousands of hours of wasted time through this process. And now this example is from a hospital system which had complicated and nuanced electronic health records. But even when working in smaller community behavioral health settings, there are often small redundancies that can be eliminated. To further this example, one rough estimate that has been suggested in this context is that duplicating information costs roughly 3 minutes per note when we're recording notes following client interactions. So as an example, for someone who sees around 6 clients each day and who works a typical schedule of 5 days a week, about 200 days per year, that's 60 hours wasted every year for one person alone. If we multiply that by the potentially hundreds of employees in an organization, many of whom might be recording more complicated notes that take longer than 3 minutes, you can immediately start to see the potential for real savings here. Arguably, even more important than the savings is also that you're sending a message to your staff. You're saying to your staff that your time is valuable. We know, we understand, and we appreciate that. Let's put your time where it matters most to you, working with your clients, providing care. Preceding systems changes with this elimination of stupid stuff can also imply something about the new things you add. These new things matter. It says, we're the kind of people who value your time, so we wouldn't add anything that dilutes your ability to care. It really puts the spotlight on those new services as new interventions that are designed to not only make the work environment better and more effective and efficient for staff, but will in turn have a positive impact on the people that they're caring for. So eliminating stupid stuff is not a requirement. Only you can know if your current systems have started to suffer from service or administrative creep or any other type of letdown. But before you embark on major alterations of your workflow, you do need to know what you're currently doing so that you can find opportunities to enhance those processes with tobacco-related additions. When you're trying to think of ways to enhance current systems by adding tobacco treatment objectives, try to think of tobacco in terms of your current workflow's goals. Think of it this way. Nicotine dependence is a dependence. Dependence in general is a chronic recurring condition. Tobacco use is a health behavior leading to known health outcomes. Tobacco use leads to the development of known physical conditions, most of which are also chronic conditions like various cancers. Tobacco use, like many chronic conditions, is treated with FDA-approved medications. Tobacco use, like many substance abuse-related conditions, have established best practices, given an A or B grade, again, from the USPSTF. And tobacco use can be treated with counseling. So in these scenarios, try to figure out basic things like, who does patient intake? How are patients sorted or triaged in your organization? Where do they go next in the workflow? And having answered those questions, add tobacco cessation services accordingly. A common workflow, for example, may be an intake process where basic information is collected, including the patient's current drug regimen, brief medical history and current compliance records. Some common screening questions may be included here as well. 2, then the person will be sent to someone qualified to assess whether their complaint is a certain issue and then also how severe it is. 3, then the person will be sent to someone qualified to reduce the severity of the complaint with an aim to moving the consumer to the least restrictive care environment. This may be a prescriber who can start a new prescription or alter current ones. 4, then the person visits an assigned case manager who will connect the client to other services, including potentially a therapist, an in-home case aide, or relevant therapeutic or educational group support. Of course, the case manager may also refer to resources outside the organization. And finally, 6, then they are sent to billing or discharge. That may or may not look like a common consumer route to you, depending on your organization. The point is not that we all should adopt a model workflow that would work anywhere, or even that all consumers within your organization follow the same route. They most certainly don't. The point is to refer back to those evidence-based tobacco interventions and to make sure that all the people who see the patient are trained to provide the service that most corresponds with the services they are already providing to those patients. For example, 1, an intake person asking for current drug use and recent medical history can also screen for tobacco use. 2, A person who can perform a PHQ-9 for depression can also do the two-question heaviness of smoking index questions to determine nicotine dependence levels. 3, a certified addictions counselor the patient is assigned to work with for their opioid recovery can also provide counseling on nicotine dependence recovery. And 4, a psychiatrist or psych nurse with prescribing authority who is familiar with the patient's current regimen may be the ideal person to recommend, explain, and monitor their NRT use. Admittedly, the complicated workflow on this slide does not seem to convey low burden, but there are 2 things I want to point out. If you were to map out any of your chronic disease consumers' workflow, it could look a lot like this as well. The second thing to point out is the distribution of the work. Although tobacco cessation can require a lot of intense service or time with the consumer, it all doesn't have to fall on any one person. And so it is experienced as a low burden task for many people when performed that way, rather than as a high burden task for one, thereby making it potentially more effective and, in all likelihood, more sustainable as well. As I already mentioned, this isn't a 5A training, but I do want to return to this concept as it's a critical way to tailor our services in a way as to ensure that everyone gets as much support as they need and that no one gets an excessive amount. That is, I want the 5As adopted to ensure healthcare equity, not healthcare quality. One way to make sure that an intervention is sustainable is to make sure it works. So we want to provide the maximum support required to 1, motivate a quit attempt, and 2, maintain that quit attempt, hopefully to success. The second thing we need to do is not provide any more care than is necessary. Additional time spent with a patient that doesn't need it, additional pharmacotherapy provided to a consumer that doesn't need it, these are both resources that when spent can't be spent on other consumers who do not need them. And for this reason, I'm advocating for equity as opposed to equality. Also, ramping up intensity on a client that doesn't require it may actually create resistance in a consumer who was initially willing to accept assistance. In other words, they might decide not to pursue a quit attempt after all. So ask is our screener. Simply put, we want to know if the person is a nicotine or tobacco user. If not, they don't need any additional tobacco-related services. Depending on your setting, this could be anywhere between 20 and 55% or more of your entire consumer base who don't need any further services after they've been screened. However, we do want to screen each of them every time they come in. While this is true for everyone, it's especially true for young people below 18 and for anyone newly exposed to high levels of smokers, such as those recently assigned to residential treatment, jail, or prison setting. People often ask, is every patient at every visit a realistic approach when consumers might be coming in multiple times per week? I have 2 answers to consider. First, probably. It literally only takes a second to ask and record an answer. And the other is, I don't know, it depends on your setting. Only you really know your workforce and staff capacity. However, I would recommend setting some parameters to measure against. Perhaps once every 12 or 24 months are 2 common standardized measures. Ideally, asking more frequently would be best since folks can change their mind overnight. Moreover, it's not just about obtaining a smoking status. Ideally, you'd want to make sure you can you catch anybody who suddenly changes the level at which they smoke. Changing levels can be an early warning sign of an acute onset for several conditions of concern, including major depression and suicidality. It can also be indicative of major life changes like loss of food stamps or other nutritional support or loss of sleep. And lastly, we should always keep in mind that as a person's consumption of smoke changes, the potency of other medications may be changing as well. That is, as smoke consumption goes down, other medications generally become stronger. So frequent check-ins to check on changes in tobacco use levels has a solid grounding in the provision of medication-related services. Now, I do want to expand a little bit on ask because people often get really hung up here. Most people are bought into the idea that assisting tobacco cessation is a good idea. Many know the 5As and think it's doable, but there's a lot of nervousness about starting the conversation, especially with those who did not previously express an interest in tobacco cessation. With that in mind, I have a few ideas to offer. The first thing is to take a breath and remind yourself of some of the points made earlier in this presentation that most tobacco users do want to quit. Then make sure to connect the opener about tobacco to the client's most present and immediate concerns. This will become easier with practice and more knowledge about tobacco-related diseases. But most care sites see the same type of issues over and over again, and most issues are connected either causally or by association with tobacco use. And then remember that in this early stage, you do need the client's participation. So be sure to ask permission throughout, and generally speaking, let them lead the conversation to the greatest extent possible. Next, we want to advise all tobacco-using clients that quitting tobacco use is the best thing they can do for their health. This message, again, should be delivered in a non-judgmental way and also connected to something that makes the advice immediately relevant to the client, which again, for example, may be connecting their tobacco use to the actual reason for their visit or perhaps their chronic disease condition. From a workflow efficiency standpoint, you will have to make the calculation of from how high up the advice comes from a provider level perspective. The higher up it comes from, the more expensive each minute becomes. But on the other hand, from an effectiveness and efficiency standpoint, an intake staffer advising someone to quit simply doesn't have the same impact on cessation rate. However, when that advice comes from a physician, it more than doubles the chance of absence after 5 months, as you can see here. In the next stage, we want to assess the client on 2 fronts. First, we want to assess the client's willingness to talk with us. If they are pre-contemplative about their nicotine use, that is, if they are among the set of individuals who have no intention of quitting ever, or at least in the foreseeable future, then we don't force any further engagement, which could even be counterproductive. This group could represent anywhere between 20 to 30% of all current tobacco users in your system. For people contemplating quitting tobacco, we really want to simply provide them with some educational resources, and if willing, and we have the time, some information regarding the dangers of tobacco use they may want to consider. Or if they have questions about how to quit, tools and resources they can use, et cetera, we can, of course, provide those things as well. So I will address the second half of assess and all of assist together. This is really our counseling component, and how much time you spend with a client will be determined by their need to some extent and your capacity to satisfy that level of need. First, I want to say, if you are thinking of providing cessation services yourself, the assess and assist stage will satisfy the condition that most insurance payers, including Medicaid, have for reimbursable tobacco cessation counseling session if it is provided by a qualified provider. That is, don't confuse counseling in this context with therapy. To satisfy counseling, a qualified provider should discuss the harms of tobacco use in ways relevant to the consumer and the benefits they can expect from quitting. Counseling also should include an exploration of the consumer's triggers, their history with quitting, and identifying potential barriers. In addition to allowing us to check the counseling box, this information allows us to create a quit plan tailored to their unique needs. Finally, some accrediting organizations want the advice or counseling piece to also include a pharmacotherapy recommendation. However, if you've opted not to provide any services yourself at all, and instead plan to refer your clients elsewhere for direct interventions, you may still consider assessing stage of change and dependency, as these will help significantly in making sure you are recommending the right interventions at the right intensity. I won't go into too much detail on the topic of assessing dependency, but I strongly recommend adopting a single validated instrument organization-wide, and if possible, adding it to your EHR. As an example, the Fagerstrom test for nicotine dependence is a validated tool that's been used effectively around the world, and due to its simplicity, may lend itself well to simple implementation. So just to recap how performing Ask Advise, stages of change assessment, and dependency might impact your workflow, I used here the results of the survey shared earlier in the presentation, again, that one using results from residential substance abuse facilities in Florida. Here we see that they were asking everyone who comes in if they are a tobacco user. In this example, approximately 69% said yes, and they were advised to quit, and also asked how ready and willing they were to quit. About 45% or 44% said they wanted to quit in the immediate future. That is actually a slight exaggeration. Normally, we divide readiness to quit between these primary groups. 1, those who plan to quit in the next 6 months are considered contemplators. 2, those considering quitting within the next 3 months are planners. And 3, those who want to quit within the next month are considered to be in the action stage. For purposes of illustrating how low your burden gets as it goes forward, I included all those who said they wanted to quit within the next year as graduating to a dependency assessment, which in reality is a service that may actually be reserved for only those in the action and planning stages. Therefore, dependency will tier the respondents into high, medium, and low categories. We don't have these figures for our survey respondents in this example, but a breakdown like what you see here is pretty common in community behavioral health and substance abuse settings, where most users are on that higher middle level tier. Since I just alluded to it, I thought I'd take a quick moment to reiterate that point and expand on it a bit. There are competing theories of what makes a best practice regarding referrals, such as a referral to the quitline. If you ask quitline managers, the North American Quitline Consortium, or the various state quitline contract managers, most, if not all of them, will tell you to refer everybody who uses tobacco. The theory is that their coaches are specifically trained to take pre-contemplative people and move them toward making a change. Therefore, there are no bad referrals. And generally speaking, I think that's a good approach. However, it also isn't a reality that all small operations can enjoy, or perhaps even many. Time is money, and as already said, resources spent on clients that won't use them are resources you can't spend on clients that will. If you have the time to refer everyone, then yes, do so. But if you or your clinic partners are facing a scarcity of resources, then you may consider focusing attention on providing resources to people who they have formally and systematically determined are the most likely to use them. Consumers prefer as many services and products as possible to be available in the same transaction space. That's why department stores like Walmart and Target have added groceries. That's why Amazon's our most popular retailer. Similarly, it's one reason among many that integration is a driving force in our healthcare delivery sector. The more important reason is that there's no hard line between mental and physical health. Some mental health issues cause physical health problems and vice versa. Some conditions co-occur because they share the same cause. So, making sure that mental and medical care is provided at the same time by a team of individuals and continuous communication is essential in the treatment of the strong type of dependence that nicotine causes. Which is to say that, all things being equal, the more of the services described above you can provide yourself, the better off the consumers are. Feeling that, you want to find a source for each service you don't provide. And ideally, you want to have a systematic link between you and those who refer to you and those who refer to you and those that you refer to. If, for example, you routinely send patients to a nearby university setting for tobacco cessation group psychoeducation, you'd want to formalize a means of getting information about the patient's progress in the group back to the provider or care team at your site. Similarly, if you regularly get referrals from a nearby jail or halfway house or something similar to that, formalizing the transfer of paperwork could mean that if they are screening for tobacco use or assessing willingness to quit, you can remove those tasks from your intake or assessment staff, thereby reducing workload on site, while simultaneously improving your patient's experience within their care. Two critical further things about referrals. One, they have to be relevant and useful to the client. Client who's informed you they are not available on Wednesdays should not be referred to a group that only meets on Wednesdays. This does not get a check in the provided referral box. Similarly, a referral to the quit line does not constitute a relevant referral if that client has insisted they don't want to use the quit line. Referrals should be made enthusiastically again. We know as well as we know anything that seeking any help for tobacco cessation can at least double the chances of success for any given quit attempt, often multiply it 3 or 4-fold. So at minimum, the quit line, a group, a counseling session, a round of NRT, all of these things are better than nothing at all. Sowing doubt undermines that success before it begins. The final 3 points on this slide all go toward developing a robust partnership with your referral sources and those that refer to you. The more knowledgeable you are about the location, times, personnel, and unique characteristics of your referrals, the more appropriate you can be assured they are. The more enthusiastic your recommendation can be, and the better you can be about setting proper expectations with the client about their future experience. And just because it's been so long since I mentioned them, I thought it might be beneficial to review visually at least who or what we are referring clients to. Not every client needs every intervention at the highest level of intensity. A brief assessment is often all that's needed to begin the process of determining which interventions are most likely to be appropriate. But as a general reference, I would begin any workflow analysis. I would determine which of these services listed here you or your partners do or can offer. And then prioritize findings which organizations in the catchment area in which you work do or can perform the others. Then proceed to building those professional linkages. Again, the Colorado Quit Line is an excellent resource here that I would encourage you to learn more about and to be able to make more informed recommendations, or I should say referrals to your clients regarding. And so finally, we need to talk about a range. A range is simply making sure we follow up with our consumers at regular intervals going forward. We want to make sure we're checking in on them about questions and concerns they may have. We want to confirm that they are taking any pharmacotherapies in the way that will control their cravings best. And so moving towards closing, here's our final to-do list. The things we discussed today that are concrete actions we can embed in current workflows to help our clients maximize their quit attempts. So again, we recommend forming a wellness committee, analyzing workflows to look for opportunities to align strategic initiatives, screening all clients, advising those who are tobacco users to quit, assessing the stages of change that they may be in and their dependency levels regarding their nicotine use, educating people on the harms of tobacco use and the benefits of quitting tobacco, providing an NRT recommendation where appropriate, perhaps not a prescription, but it could also be over-the-counter recommendation. We can refer people to the USPSTF recommended services that I outlined earlier. Following up with patients is an important component in this and something that we should do for consistency and to check in on progress. And we want to embed all new services into a comprehensive nicotine-free policy that not only provides a framework for having that policy in place, but also explains the necessity and benefits of the policy and the services associated with it. And we want to use data to be responsive to patient needs and assist staff in improving health outcomes for patients. And okay, and so to reiterate, this webinar will be uploaded to the BHW YouTube page this week, and will make its way onto the Tobacco Innovative Grant Project landing page when that's revamped over the summer. As a final reminder, I am currently recruiting for the fiscal year 2024 cycle of the TIG project, which will begin July 1st and run for a full year. So to reiterate, if your organization or another organization you might be aware of is interested in pursuing tobacco-related goals and receiving free intensive tobacco training opportunities, such as our Dimensions Tobacco-Free Group program and our Rocky Mountain Tobacco Treatment Specialist Training Program, as well as offering tailored technical assistance in the process, please do let me know. And with that, we have a couple of minutes. I'd like to open it up to the audience to see if you have any questions. Feel free to unmute yourself and ask those, or I'll also monitor the chat box.
Hi, Derek. I have a quick question.
Yes. Hi, Robin.
Hi, how are you?
Good. Thanks for joining.
Good. I enjoyed that. Is Varenicline still on the market, or is it just Chantix that's been pulled off?
So the product that's coming off the market is actually the nicotine inhaler. Pfizer has decided to stop producing that product, and so basically when it runs out of stock, it will no longer be available, and that's expected to be perhaps in the fall. Fortunately, that's potentially, but it's between one or the other, but it may be the least commonly used form, so it shouldn't have too big of an impact. But thanks for bringing that up.
Okay, great. Thank you. I just want to clarify that. Thank you.
You're most welcome. Any other questions in the time we have remaining? Well, I thank you all for joining today. Again, this webinar will be uploaded to our YouTube page, and appreciate your attention, and thank you very much. Have a great day.
You too.
Thanks.